This PowerPoint is going to cover Chapter 8, which is over the gynecologic examination as well as prenatal care. This is going to be a little bit more of a lengthy PowerPoint. It's going to be a bigger chapter in your book, but it is very important. The MA should have knowledge of gynecology and obstetrics to assist in examinations and treatments in these specialties. Gynecologic examinations are frequently and routinely performed in the medical office. Prenatal care consists of a series of office-scheduled visits for the promotion of the health of the mom and the baby during pregnancy. Obtaining patient's cooperation makes the gynecologic or prenatal exam go more smoothly and makes the patient feel more comfortable. We need to make sure that we are explaining the purpose of the exam. So why are they getting the exams? Obviously, it's going to make them more likely to comply, and it's going to make them more comfortable and more informed about their health care. The first part of this chapter we're going to talk about is the gynecologic examination. So if you don't know what gynecology is, it's the branch of medicine that deals with health maintenance and diseases of the female reproductive system. This is going to include a breast and pelvic examination, so that's the two main parts, breast and pelvic examination. And the purpose of the gynecologic examination is to assess the health of the female reproductive organs to detect early signs of disease leading to early diagnosis and treatment. This examination may be included as a part of a general examination, a general physical examination, or by itself. Although assisting with a gynecologic examination is a routine procedure, the patient may not consider it routine. And to reduce apprehension or embarrassment, we should fully explain the procedures and offer to answer any questions for them. On the first couple of pages here inside of this chapter, there's going to be a lot of terms that are listed that relate to gynecology, and I want you to know all of them. So first up, we have amenorrhea, which is absence or cessation of the menstrual period, and it occurs normally before puberty, during pregnancy, and after menopause. We have cervix, which is the lower narrow end of the uterus that opens into the vagina. Then we have colposcopy. This is an examination of the cervix using a colposcope. Dysmenorrhea, which is pain that's associated with menstrual period. Dyspareunia, which is pain in the vagina or pelvis experienced by a woman during sexual intercourse. Dysplasia, which is the growth of abnormal cells, and it's a precancerous condition that can or it may not develop into cancer. I do want to say I accidentally somehow put this slide in here when it's literally the same slide as the previous one, but there are more words to know. So look in your book after dysplasia. The next one is going to be menopause. Menopause is the permanent cessation of menstruation, which usually occurs between the ages of 45 and 55. Then we have menorrhagia. This is excessive bleeding during a menstrual period in the number of days, the amount of blood, or both. We have metrorrhagia, which is bleeding between menstrual periods. Perimenopause, which is before the onset of menopause, the phase during which a woman with regular periods changes to irregular cycles and increased periods of amenorrhea. We have perineum, which is the external region between the vaginal orifice and the anus in a female and between the scrotum and the anus in a male. And then we have the word risk factor, which we've seen before, and this is anything that increases an individual's chance of developing a disease. Some risk factors can be avoided or changed, and others cannot. So some that can be changed would be like your smoking, diet, your habits, and then some that can't be changed would be age, family, race, gender, those types of things. The provider usually begins the gynecologic examination with the breast examination. The MA is responsible for assisting the patient to a supine position, so we're going to lay them flat on their back. The provider inspects the breast and nipples for swelling, dimpling, puckering, and any changes in skin texture. The nipples are also checked for bleeding and discharge and any other abnormalities. And the breast and axillary lymph nodes are palpated for any lumps, hard knots, or thickening. The patient should know how to perform a breast self-examination, a BSE, and examine their breast for lumps or other changes. Most breast cancers are first discovered by women themselves, and the AGOG, American College of Obstetricians and Gynecologists, recommends that women 20 years of age and older examine their breast once every month. If they don't know how to do this, We are the ones that are responsible for helping them and ensuring that they know how to do this at home. Women of 20 plus years should do this monthly, and if lumps or changes are noticed, the patient should schedule an appointment with their provider as soon as possible. Most lumps are benign, which means they're not cancerous, but the provider is ultimately going to make the final diagnosis after looking into it more. The next part of our gynecologic examination is going to be the pelvic examination, and the purpose behind this is to assess the size, shape, and location of the reproductive organs and to detect the presence of disease. It's going to consist of the following: so inspection of external genitalia, the vagina, and the cervix, collection of a specimen for cervical cancer screening, pap smear, bimanual pelvic examination, and a rectal vaginal examination. For the pelvic examination, the patient is positioned in the lithotomy position. So the patient is going to lie on the back, on the table on her back with her feet in the stirrups and her butt at the bottom edge of the table. The stirrups should be level with the examining table and pulled out about 1 foot from the edge of the table. The patient's knees should be bent and relaxed, and her thighs should be rotated outward as far as comfortable. This position helps relax the vulva and perineum and facilitates insertion of the vaginal speculum. The patient should be properly draped to reduce exposure and to provide warmth. In the lithotomy position, it can be difficult to maintain, and the patient should not be placed in this position until the provider is ready to begin the exam. I did place a picture in here so you could get a visual. This is not always what it's going to look like. This one has the legs specifically in the stirrups. This is more like a labor and delivery type picture here. But for some reason, I could not find a good picture to go inside of this slide. So most of the time they'll have where you just put your feet in the stirrups, but they can have these where they put your legs in the stirrups. We can help the patient relax during the exam by telling her to breathe deeply, slowly, and evenly. If the patient is relaxed, it does make it a whole lot easier for the provider to insert the speculum and to perform the bimanual pelvic examination. It also makes it more comfortable and less painful for the patient. It's not supposed to be really painful, but some cases it can be. Next, we're going to look into the inspection of external genitalia, vagina, and cervix. So the provider begins the pelvic examination with the inspection of the external genitalia. The vulva is inspected for swelling, ulceration, and redness. Next, the provider inserts a vaginal speculum into the vagina. Specula are available in 2 different types. We have a plastic and we have a metal. Plastic are going to be pretty common because they can be disposable, and a lot of times they can put a little light on these as well. I've seen some with a light. The metal are reusable, and they do have to be sterilized to be used again, obviously. These are going to be colder than the plastic ones, so they do need to be warmed first by placing it on a heating pad or a warming drawer. But we want to make sure that since it's metal, we don't overheat. Now, I can't say that every doctor's office is going to warm them up for the patient, but according to our book, they are supposed to be warmed up. These also can come in different sizes, depending on the place. They might have all the sizes or they might just have a couple, but the provider is going to determine the size required based on the physical and sexual maturity of the patient. This is important. The function of the speculum is to hold the walls of the vagina apart to allow visual inspection of the vagina and cervix. The provider inspects the vagina and cervix for color, lacerations, ulcerations, redness, nodules, and discharge. If an abnormal discharge is present, they can obtain a specimen and send it off to the lab to see what it could be. Examples of pathologic conditions that can produce discharge include vaginal infections like bacterial vaginosis, vulvovaginal candidiasis, which is a yeast infection, trichomoniasis, chlamydia, and gonorrhea, which we will talk about later in this chapter. Cervical cancer screening is used for the early detection of cancer of the cervix. Almost all cervical cancers are caused by HPV, the human papillomavirus, which is a common virus that can be transmitted from one individual to another during sexual intercourse. There are many types of HPV, but most do not pose a health risk. Some of them are called high risk because they can cause abnormal changes to the cervical cells known as dysplasia that can lead to cervical cancer over time. Although infection with the high-risk HPV is the most important risk factor for the development of cervical cancer, there are other factors that place a woman at higher risk for cervical cancer, which include cigarette smoking, weakened immune system due to HIV, organ transplant, chemo, or long-term steroid use, having given birth to 3 or more children, the use of oral contraceptives for more than 5 years, diethylstilbestrol DES exposure before birth. Nearly all cancers of the cervix can be cured if detected early enough. Cervical cancer screening consists of 2 types of tests, the HPV test and the Pap test, which we'll talk about next. The Pap test is a simple and painless cytology evaluation. To perform the evaluation, a sampling of cells is collected from the cervix and examined under the microscope for the presence of abnormal cells. The primary purpose of this is to detect abnormal cells, dysplasia, that may develop into cervical cancer if not treated. It usually takes years or even decades for abnormal cervical cells to develop into cancer. The Pap test can also determine the presence of non-cancerous conditions such as infection and inflammation. The Pap test detects the presence of cancer cells. However, in regularly screened individuals, most abnormal cells are discovered before they become cancerous. In some cases, the Pap test can detect cancer of the endometrium. However, it is less reliable in doing so. And typically for your Pap smear or your Pap test, they're going to start doing it about the age of 21, and you're supposed to get them every 3 years or so. So our other tests for our cervical cancer screening includes HPV. HPV test is a DNA test that detects the genetic material of high-risk types of HPV that have infected the cervical cells. About 70% of all cervical cancers are caused by HPV type 16 and 18. The HPV test can be performed on the same liquid-based cytology specimen that is collected for a Pap test. Essentially, the Pap test looks for the presence of abnormal cells of the cervix, while the HPV test looks for high-risk HPVs that may cause the cervical cells to become abnormal. Performing an HPV test is not necessary under the age of 30 unless it's needed following an abnormal Pap test result. This is because cervical HPV infections in younger women usually go away on their own without causing any problems. We do have some preparation for our patients for this cancer screening, cervical cancer screening. So it's recommended that the specimen not be collected during the patient's menstrual period. The patient should be instructed to schedule cervical cancer screening about 10 to 20 days after the first day of her last menstrual period. The patient should be told not to douche, insert tampons, vaginal medications, lubricants, contraceptive spermicides into the vagina for 2 days before having the cervical cancer screening. Douching and tampon insertion reduce the number of cells available for analysis, and vaginal medications, lubricants, and spermicides change the pH of the vagina, making the specimen non-representative or invalid. The patient should also be told to abstain from sexual intercourse for 2 days before undergoing cervical cancer screening. Recent sexual intercourse can produce inflammatory changes that can interfere with visualization of abnormal cells that may be present. So tell them to keep anything and everything out of their vagina for a couple days before. For specimen collection techniques, there is a little figure, figure 8.3. It's got A, B, C, D, and it kind of helps you visualize what these techniques look like. So with a vaginal speculum in place, the provider is going to collect a sampling of epithelial cells from the cervix for evaluation by the lab. We can collect it from both the ectocervix and the endocervix. And the ectocervix is going to be the outermost layer of the cervix that projects into the vagina and consists of a thin, flat layer of cells about 10 layers thick. The endocervix is going to be the inner part of the cervix that forms a narrow canal that connects the vagina to the uterus. It's lined with a mucous membrane made up of simple columnar epithelial cells that can produce mucus. I do want to specify that this will be the doctor doing this, not us, but you may be the ones that are helping to assist with anything, hand them some tools if they need them, support the patient. So our vaginal specimen, if a vaginal specimen is needed, it's to be collected first before the ectocervical and endocervical specimens are obtained. The rounded end of a plastic cytospatula is used to collect this specimen. If a routine vaginal specimen is being obtained, it's collected from the vaginal pool in the posterior fornix of the vagina, which is located just below the cervix. If the provider is collecting a specimen from a lesion on the vaginal wall, a scraping of cells is taken from the area of the lesion. To obtain a specimen for determination of the maturation index, which we look at in just a little bit, the provider obtains the vaginal specimen from the upper 1/3 of the lateral vaginal wall. For an ectocervical specimen, the provider collects this by placing the S-shaped end of a plastic cytospatula just inside the cervical canal at the external OS. This is the opening of the cervical canal of the uterus into the vagina. The physician next rotates the blade of the cytospatula 360 degrees over the surface of the ectocervix at the squamo-columnar junction where cervical cancer is most often found. From the endocervical specimen, they collect it by inserting the cytobrush into the endocervical canal and rotating it. This is made up of soft bristles designed to be inserted into the canal without causing any damage to it. A scraping of cells from the ectocervix and the endocervix can be collected at the same time by using a flexible plastic collection device known as a cytobroom. The provider inserts the central bristles of the cytobroom into the endocervical canal deep enough to allow the shorter bristles to contact the outside of the cervix fully. The cytobroom is gently pushed and rotated in a clockwise direction to collect an ectocervical and endocervical combined specimen. The most commonly used method to prepare a cytology specimen for evaluation is the liquid-based method. Some brand names of these include ThinPrep and SurePath. If I can find these, I'm pretty sure we have some. I'll lay them out for y'all to see. Following collection, the specimen is placed in a plastic collection vial containing a liquid preservative. So similar to when we're doing swabs and things for like strep throat. The preservative maintains the specimen and prevents it from drying out during transport to the lab. Use of the liquid-based method provides a high-quality specimen which results in fewer slides that are unsatisfactory for evaluation. A high-quality specimen also helps to reduce the occurrence of a false negative test result. The specimen for a liquid-based preparation is obtained using one or more of the specimen collection techniques that we just talked about, and this is usually based on the doctor's preference. A plastic cytospatula with an S-shaped end can be used to collect the ectocervical specimen, and a cytobrush can be used to collect an endocervical specimen. Alternatively, a cytobroom can be used to collect an ectocervical and endocervical combined specimen. If a vaginal specimen is needed, like we talked about just a second ago, we are going to collect it first, and we're going to use the rounded end of a cytospatula. Once the specimen has been collected, the medical assistant is responsible for performing one of the following steps depending on the brand of liquid-based preparation being used. Number 1, rinse the collection device in the vial of liquid preservative and discard the collection device. This is performed with ThinPrep. Number 2, remove the tip of the collection device, deposit it in the vial of preservative, and discard the handle. This is performed with the SurePath. Next section we have here is cytology request and general information included within it. So if you were in my med lab class, you have heard of what a lab requisition form is. So it's essentially something that whenever we are going to send off a specimen to be tested, we have to have this request form, which has all kinds of information about the patient and what type of test and specimen we're going to do and what type of specimen we're going to have. We do have to have a cytology request for all Pap specimens. There is a great picture of what one of these looks like in your book. It's figure 8.4. And we're going to be the ones that are responsible for completing the request. Some information that's included, general information, includes the provider's name, address, and phone number, the patient's name, address, and ID number, their date of birth, the date of their last menstrual period, and then information from their insurance is also required. We also need the date and time of collection of the specimen, which provides information on how fresh it is. The provider needs to have written down the test that's required, so what they're wanting to order. And we also need the source of the specimen, which identifies the origin, so where it's coming from. So ectocervical, endocervical, or vaginal. We need to have the collection technique, so the device that's used, whether it was spatula, brush, or broom. We need to have patient history, so including things like their present and past health status, whether they're pregnant, lactating, on birth control, postmenopausal, going through hormone replacement therapy, if they have postmenopausal bleeding, if they're postpartum, have an IUD, have postcoital bleeding, diethyl stilbestrol exposure, and previous abnormal pap test. There's a section for previous treatment, so if they've had any treatment for precancerous or cancerous conditions of the cervix, like a colposcopy and biopsy, cryotherapy, a LEEP, laser treatment, conization, hysterectomy, radiation, and chemotherapy, that needs to be placed in this section. Continuing with this still, we need to have the evaluation of the specimen. Before evaluation, the specimen is processed and stained. Staining allows for better viewing of morphology of cells. The slide is going to be studied under a microscope afterwards. There's a little section under here called maturation index. This is the percentage of parabasal, intermediate, and superficial cells present in the specimen. This provides endocrine evaluation of the patient, which can assist in evaluation of infertility, menopausal or postmenopausal bleeding, or amenorrhea. It must be performed on a sampling of cells from the upper third of the lateral vaginal wall. Next, we have a cytology report, which is kind of mean the opposite of a request. So we send over the request to tell them, hey, we want this to be done. Here's the specimen. They're going to send a report back from the lab and give us what is going on with the specimen. So give us the results, essentially. So the report is separated into two sections. We have the specimen adequacy. Well, I guess technically 5 sections. We're going to go over 2 over here, 2 main sections here. So the specimen adequacy, which is the quality of the specimen. So it's either satisfactory or unsatisfactory. Satisfactory for evaluation means the specimen was sufficient sampling and quality. And unsatisfactory means overall sampling or quality of specimen was inadequate. So too few cells, presence of blood, inflammation, obscuring the cells. The next category we have is general categorization. This provides medical offices with a quick view of the report. So we have negative for intraepithelial lesion or malignancy that indicates epithelial cells were normal and there's no precancerous or cancerous findings. It's also assigned to specimens that exhibit benign changes. Then we have epithelial cell abnormality, which indicates abnormal cell changes. And then we have other, which is used to indicate no abnormality was found in cells, but findings indicate some increased risk. Next category that we have is interpretation/result. This provides the provider with a detailed description of the findings. It includes significant benign changes and abnormal changes in the cells. Then we have automated review, which indicates whether the specimen was evaluated using automated computer imaging device. And then lastly, we have ancillary testing, which is used if additional test methods were used to evaluate the specimen. Abnormal pap test results can be caused by infections and inflammation, precancerous lesions, and cancerous lesions. Although an abnormal pap test result is found in every 1 in 10 tests, most abnormal results are not due to cancer, but rather inflammation or infection. This is a screening test, therefore, an abnormal test must require further evaluation before they can come to a final diagnosis. Next up, we have bimanual pelvic examination. After obtaining the smear for the pap test, the provider withdraws the speculum and they perform a bimanual pelvic examination. The provider inserts the index and middle fingers of a lubricated gloved hand into the vagina, and the fingers of the other hand are placed on the woman's lower abdomen. Between the 2 hands, the provider can palpate the size, the shape, and position of the uterus and ovaries, and they can detect tenderness or lumps. The last part of the pelvic examination is a rectal vaginal examination. So the provider inserts one gloved finger into the vagina and another gloved finger into the rectum to obtain information about the tone and alignment of the pelvic organs and the adjacent region. The presence of hemorrhoids, fistulas, and fissures can also be noted. During this examination, the provider may want to obtain a fecal specimen from the rectum to test for occult blood in the stool, which is something that you already went over Tuesday, but it's hidden blood that's in the stool. This is typically performed on women beginning at 40 years of age. The medical assistant is responsible for assisting with the collection and testing of the specimen for occult blood. I will say, not with every single examination that they do, every single gynecological examination, they won't always include this, and they won't always include the occult blood test. Okay, now we're moving on to something a little bit more interesting, I think. So gynecologic infections. Gynecologic infections are actually going to be classified into two different categories. We have vaginal infections and we have sexually transmitted infections, STIs. STIs are also referred to as STD, sexually transmitted diseases, but nowadays they use STIs instead of STDs. Vaginal infections are caused by overgrowth of an organism that's normally present in the vagina, while an STI is going to be caused by the transmission of a pathogen through sexual contact with an infected partner. In most areas, vaginal infections are more common than STIs. The medical assistant is responsible for assembling the appropriate supplies for the collection of a suspected pathogen. We must label the specimen with the patient's name and date of birth, the date, and the source of the specimen. If it's going to be transported to an outside lab, we also have to have that request form completed, which indicates the source of the specimen, the physician's clinical diagnosis, which is what they think it is, and then the lab test that's requested. The physician's clinical assessment of the patient's signs and symptoms, the physician's clinical assessment of the patient's signs and symptoms, along with the results of the lab evaluation of the specimen, are used to diagnose the presence of a gynecologic infection. Medical assistants should protect themselves from infection with the pathogen while assisting with the collection of the specimen by practicing good techniques of medical asepsis, which we talked about in one of the first couple of chapters. So we're going to start off diving into vaginal infections first. So the vagina provides a warm, moist environment, which tends to encourage the growth of various organisms. So like we learned about in one of the first couple of chapters, pathogens and microorganisms love a dark, moist, warm environment. So this can encourage that growth that can result in these infections. If an unusual vaginal discharge is present, suggesting a vaginal infection, a specimen is obtained to identify the invading organism. A specimen of the vaginal discharge is collected at the medical office and evaluated there or placed in an appropriate specimen container, and then they'll send it to an outside lab for evaluation. The patient should be instructed not to douche or use a feminine hygiene product before coming to the medical office because the physician may not be able to observe the discharge or to obtain a specimen for analysis. The most common infections, and we'll talk about each one of these on the next couple of slides, but the most common ones are going to include bacterial vaginosis, vulvovaginal candidiasis, which is a yeast infection, trichomoniasis, and then we'll discuss the STIs later too. So first, we're going to start off with bacterial vaginosis. You'll commonly hear this referred to as BV. And this is going to be the most common cause of abnormal vaginal discharge in women of childbearing age, so 14 to 49. This is caused by an imbalance in the normal flora of the vagina known as vaginal flora. The factors that upset the normal balance of the vagina or vaginal flora are not yet completely understood. The majority of vaginal flora consists of lactobacilli, which are beneficial to the body. When the flora is altered, anaerobic bacteria normally present in the vagina in small numbers begin to grow and multiply, which results in the replacement of the beneficial lactobacilli with harmful anaerobic bacteria, along with a decrease in the acidity of the vagina. The normal pH of the vagina ranges from 3.8 to 4.5, which is considered mildly acidic, and it works to repress the growth of these harmful anaerobic bacteria. So when that pH, instead of being acidic, it turns to alkalotic, then it's going to create a better place for bacteria to live and grow and thrive. Many women are not going to have any symptoms, but when symptoms are present, they can include a grayish-white vaginal discharge, which has a foul-smelling or fishy odor. Factors that increase the risk of getting BV include vaginal douching, new or multiple sex partners, IUDs, recent antibiotic usage, and cigarette smoking. If untreated, it can lead to significant health complications like increasing the risk for STIs. It can increase the risk for pelvic inflammatory disease, which is PID, pregnancy complications, and post-surgical complications following gynecology procedures. BV can be identified using a sterile swab with vaginal discharge placed on a microscope slide with a drop of isotonic saline. It's going to get viewed underneath the microscope, and the provider looks for clue cells, which is a good indicator that BV is present. The provider can also check the vaginal pH to determine if it's higher than 4.5. They can also perform a whiff test, which uses KOH, potassium hydroxide, that's what that is, 10% potassium hydroxide, to check the odor for a fishy smell. The provider may prefer to send this to the outside lab for evaluation using a nucleic acid hybridization test, an NAT. For treatment, several antibiotics are effective, so we have Flagyl and Metrogel. There's also vaginal creams like Cleocin that's also effective, and then Tindamax can also be used and tend to have fewer side effects. They might require a second treatment because it has a tendency to reoccur, so that first one might not work, and we need to tell them that it can be normal, so to watch out for more symptoms. Next, we have vulvovaginal candidiasis. This is also known as a yeast infection. So Candida albicans is a yeast-like fungus that's normally found in the intestinal tract, and it's a frequent contaminant of the vagina. However, it usually does not produce any symptoms indicating a vaginal infection. Conditions that can cause it include pregnancy, diabetes mellitus, weakened immune system, and prolonged antibiotic therapy. This is commonly referred to as a yeast infection, like I've mentioned. And some symptoms that we can see with this include white patches on the mucous membrane of the vagina, a thick, odorless cottage cheese-like discharge, vulval irritation, dysuria, which is painful or difficulty urinating. Discharge is extremely irritating, and it can result in burning as well as intense itching. For diagnosis and treatment, it's identified microscopically by placing the specimen of discharge on a slide with a drop of 10% KOH, which is going to help dissolve debris and allow better visualization of yeast buds, spores, or hyphae. We can also send this out to an outside lab, but it must be placed in the appropriate container, and they're going to do the DNA probe test. For treatment, there are vaginal ointments or suppositories like Monistat, gynotrimin, and mycostatin. And there's also an oral administration of diflucan that can be used. This also does have a tendency to recur, so patients should contact the office if any symptoms reappear, just in case they need a second dose of medication. Lastly, for vaginal infections, we have trichomoniasis. This is classified as an STI as well because it is spread through sexual intercourse. Patients may not have any symptoms, but if they do, it can include profuse frothy discharge that's a yellowish green and has an unpleasant odor, itching and irritation of the vulva and vagina, dyspareunia, dysuria, and the cervix can have small red spots, and they call this strawberry cervix. Diagnosis and treatment. This can be identified through a wet prep, which involves placing discharge with a drop of isotonic saline. The provider looks under the microscope for lashing movements of flagella and motility of the organism. It can also be sent to an outside lab and tested using the DNA probe test. For treatment, oral administration of metronidazole or tinidazole are given. The woman and sexual partner must both be treated to prevent infection. All right, next we have sexually transmitted infections. These are commonly spread through sexual contact with an infected individual. Most initially don't cause symptoms, which results in greater risk of transmission because they don't know they have it and they keep just having sex and they give it to more people. The most common STIs are chlamydia, gonorrhea, genital herpes, and HPV, but some other ones do include Hep B, syphilis, and HIV. Chlamydia, gonorrhea, and syphilis are curable, while genital herpes, HPV, Hep B, and HIV are not curable. First up, we have chlamydia. This is the most frequently reported and the fastest spreading STI, especially in younger females. Routine screening of sexually active females should start at 25 or younger, and for 35 or older if they have new or multiple sex partners or a partner who has an STI. Most women have no symptoms, but if they do occur, they can have dysuria, itching and irritation of the genital area, and yellowish, odorless discharge. Sorry, this word discharge is supposed to be up here. That's just a typo error. Symptoms usually occur about 1 to 3 weeks post-infection, so those 1 to 3 weeks beforehand, they might not have symptoms yet, and they might not know they have it. After the infection, chlamydia attacks the cervix, which can result in cervicitis, so an inflammation of the cervix. If it's not treated, it can spread further into the female reproductive tract, and it can cause pelvic inflammatory disease. And some symptoms that we can see with pelvic inflammatory disease include lower abdominal pain, fever, nausea, and vomiting, dyspareunia, vaginal discharge, and bleeding between periods. Complications of pelvic inflammatory disease are serious and include chronic pelvic pain, scarring of fallopian tubes, ectopic pregnancy, and infertility. Symptoms in men include mild dysuria and a thin, watery discharge from the penis. Men are more likely to have symptoms than women, and if they're not treated, it can cause epididymitis, which is a painful condition of the testicles that could result in infertility. For diagnosis and treatment, the recommended test is going to be the NAA test, which is the nucleic acid amplification test. This is considered to be the most sensitive and promising test for identification of both chlamydia and gonorrhea. Some types of specimens that can be used with NAA are endocervical, vaginal, and urethral. Women who don't need a pelvic exam as part of their evaluation can do a patient-collected specimen, which is where they collect it instead of the provider. The NAA test can use a first catch urine specimen, which involves the collection of urine that's remained in the bladder for 1 hour. This is the preferred specimen in males. For treatment, when it's diagnosed early, it can be treated successfully with antibiotics like Zithromax and doxycycline. And the patient's partner should be tested as well and given treatment if needed. For gonorrhea, I did accidentally mix up these two slides. So this slide and the next slide are just flip-flopped, but I'm going to read this stuff from your book. So gonorrhea is caused by a bacteria called Neisseria gonorrhoeae, which is a gram-negative diplococcus. Gonorrhea is an infection of the genitourinary tract that's transmitted through sexual intercourse, and is often associated with chlamydia. So you can see chlamydia and gonorrhea together. Approximately 25 to 40% of patients infected also have chlamydia. The CDC recommends annual routine screening for gonorrhea of all sexually active females 25 years or younger. It also recommends annual screening for women older than 25 with risk factors such as new or multiple sex partners or a sex partner who has an STI. Women who have contracted gonorrhea may have no symptoms, or they might exhibit dysuria and an increased vaginal discharge that is yellow in color. The symptoms of gonorrhea appear 2 to 10 days after infection, and they might be so mild they're ignored. But as the disease progresses, it can spread further into the reproductive tract, which can result in pelvic inflammatory disease. As mentioned previously, this can lead to serious complications such as infertility. Men who have contracted gonorrhea tend to exhibit more symptoms than women, which include dysuria and a whitish discharge from the penis, which may progress to a thick and creamy discharge. The burning and pain experienced during urination are often severe, which usually prompts an infected man to seek early treatment. If not, it can cause epididymitis, which could lead to infertility. The recommended test is the NAA test, which detects the presence of genetic material of gonorrhea bacteria. The types of specimen used are the same as chlamydia. For treatment, we can treat it with antibiotics, but it has recently become resistant. So now recommendations are showing that we should use dual therapy, which is using 2 drugs. This includes an injection of ceftriaxone and an oral dose of azithromycin. The patient's partner should also be tested and given treatment if needed. And then once again, this is just that slide that's supposed to be previous. And that one's also supposed to be previous. So the next one that we have is genital herpes. I think this might be one of our last ones. So genital herpes, it's one of the most common STIs in the US. Not the most common, but one of the most common. It's most common in the ages of 14 to 49 and more common in women. And it's caused by the herpes simplex virus, most commonly HSV2. HSV is more common with cold sores, but it can be transmitted to the genital area during oral sex. Most people don't have symptoms. If they do, it can include very mild symptoms that go unnoticed or get mistaken for other conditions. They can have small fluid-filled blisters on or around the genitals, anus, or the lips. These blisters break open, resulting in painful sores or ulcers, but they usually scab over and heal within 2 weeks. You can have systemic symptoms that occur like fever, muscle aches, swollen lymph nodes, and headaches. There's no cure. Once they're infected, the virus stays in their body for life and they can get recurrent outbreaks. So it's not like they're always sick with it. They don't always have an outbreak constantly. And it depends on the person and their body, how often those outbreaks occur. For diagnosis and treatment, the recommended diagnostic tool is going to be the NAA test that detects the genetic material of herpes virus. For treatment, there's no cure, but they can take antiviral medications to shorten the length and severity of an outbreak, especially like that first day that they notice symptoms. So some of the ones you're going to see are acyclovir, valacyclovir, or valacyclovir, as my husband likes to call it, and famciclovir. Taking a daily dose of an antiviral suppressive therapy can help prevent or decrease the number of outbreaks and reduce the likelihood to transmission to others. This one here is our last sexual transmitted infection. So this one is going to be the most common STI in the US. It's HPV. It's transmitted through skin-to-skin contact during vaginal, anal, or oral sex. Most people don't know they have symptoms and they don't know they're infected. In some cases, infections persist and they eventually cause genital warts or precancerous lesions. HPV infections can be divided into 2 categories, low versus high risk. So low risk is going to be a low risk of causing cancer that can result in the development of genital warts. Genital warts cause discomfort and pain and usually appear as flat lesions, cauliflower-like bumps, or tiny stem-like protrusions. They can affect the vulva, vagina, cervix, and anus in women, and penis, scrotum, and anus in men. A diagnosis is usually made through visual inspection, and treatment for these can include topical meds, cryosurgery, electrocautery, laser treatments, or surgical excision. Our other category is high risk, which means they have a high risk of causing cancer and can lead to precancerous lesions, which may eventually result in cancer of the cervix, the vulva, vagina, penis, anus, mouth, or pharynx. It usually takes decades or years for cancer to develop. The only HPV-related cancer for which routine screening is recommended is cervical cancer, and we just previously talked about this. We talked about how it includes the Pap test and the HPV test. They should have a Pap test every 3 years, starting at 21. There's no screening test available for high-risk infections or abnormal cell changes that lead to HPV-related cancer, and there's currently no treatment that will eliminate it from the body. There are treatments that help for the health problems that can result from persistent HPV infections like HPV-related cancers and genital warts. And there is a vaccine that's available to prevent sexually transmitted HPV infections that may lead to HPV-related cancers or genital warts. These should be administered prior to becoming sexually active. We're officially about halfway through the chapter, so we're done talking about the gynecologic examination, and now we're going to move on to prenatal care. So, obstetrics, this is the branch of medicine that deals with the supervision of women's health during pregnancy, childbirth, and puerperium. Prenatal care refers to the care of a pregnant woman before the delivery of an infant. It consists of a series of scheduled medical office visits for promotion of the health of the mother and fetus through prevention of diseases and early detection, diagnosis, and treatment of problems common to pregnancy. Early detection of medical problems uh, helps prevent serious complications in the mom and the baby. There are a bunch of obstetric terminology. If you will just review those that are in the book under that next little section, just know those for the exam. Medical office visits for prenatal and postpartum care of the pregnant woman can be grouped into three major categories: the first prenatal visit, return prenatal visits, and the 6 weeks postpartum visit. The initial prenatal visit generally occurs after the woman has missed her second menstrual period. If any problems exist, then after her first missed period. This can often be a stressful experience, and we play an important role in helping the patient relax and relieving that anxiety. It does require more time than the subsequent prenatal visits because we have to find out a lot more information. Some components include completion of the prenatal record form, an initial exam with the physical, so breast, abdominal, and pelvic, patient education, and lab tests. Sometimes these prenatal visits also depend on if they have been previously pregnant or if they've had previous gynecological issues and things like that. The prenatal record provides information regarding the past and present health of the patient and serves as a database and flow sheet for subsequent prenatal visits. The prenatal record is essential in helping identify high-risk patients, so people that need to be watched a little bit more throughout their pregnancy. The MA is usually responsible for collecting a portion of the information required for the prenatal record. Obtaining and documenting information in the prenatal record from one visit to the next provides an opportunity for the MA to develop a report with the patient. It's also an excellent time to relay information regarding various aspects of the prenatal and postnatal periods, like changes that occur in the body, signs and symptoms of labor, nutrition of the infant, so breastfeeding and bottle feeding, and then care of the newborn. The prenatal record form should be completed in a quiet setting that's free from distractions. This gives the patient the confidence to discuss areas of concern openly, which helps ensure a complete and accurate prenatal history. Our past medical history is going to focus on conditions that could affect the health of the mom and baby, like diabetes, hypertension, heart disease, autoimmune disorders, kidney disease, liver disease, varicosities or phlebitis, alcohol and tobacco intake, drug addiction, Rh sensitization, pulmonary disease, bleeding tendencies, surgeries, anesthetic complications, previous abnormal pap test, infertility problems, STIs, and drug allergies. In addition, the medical assistant solicits information from the patient regarding immunizations and childhood diseases to provide the provider with the information needed to assess her antibody protection against such diseases. Rubella, if contracted during pregnancy, can be dangerous to the developing baby. The earlier in pregnancy the infection occurs, the greater is the chance of birth defects. The infant may be born with heart defects, cataracts, intellectual disabilities, and deafness. Patients who do not have antibody protection against rubella are given a rubella immunization within 6 weeks of delivery. This vaccination cannot be given to a pregnant woman because it may be harmful to the fetus. These patients should be told to avoid exposure to children with rubella during their pregnancy. Obviously, that's hard sometimes because you don't know what different diseases that people may have. We're also going to take a look at menstrual history. So this is going to include the date of onset of menstruation, or menarche is the word that they use that. So when was their first period, their menstrual interval cycle. So, how many days is their cycle in between, the duration, how long, the amount of flow. Are they a heavy bleeder? Are they a spotter? Is it moderate? Do they have any gynecologic disorders like endometriosis, PCOS, fibroids, those types of things? Also, there's a section to indicate whether the patient was on a birth control pill or a contraceptive when she became pregnant. Then we have obstetric history, which provides information from patients related to previous pregnancies. So it includes gravidity and parity. Gravidity is recorded using one digit, and it indicates the number of times that a woman has been pregnant, including this current pregnancy. And then parity refers to a condition of having born offspring regardless of the outcome. It's recorded using 4 abbreviations and digits, which are shown on the next slide. So they usually say GTPAL. G is the gravidity, how many times they've been pregnant, counting that pregnancy, and then we have TPAL. T is for term birth. This is delivery after 37 weeks, regardless of born, alive, or stillborn. Preterm birth is P. This is the delivery of between 20 and 37 weeks, regardless of if they were born alive or stillborn. Abortion, this is a tricky one because this is not just people going and getting an abortion. It can be the termination of a pregnancy before the baby reaches an age of viability before 20 weeks. So it can be elective. They can choose to have an abortion, it's considered here, but it also can be spontaneous, which would be considered a miscarriage, chemical pregnancy, ectopic pregnancy, molar pregnancies, those types of things. And then the L is going to be living children, so it's the number of living children that they have. Obstetric history continued. If a woman is a multigravida, information about each pregnancy is obtained. Multigravida means that they've had more than one pregnancy. We need to get the date of delivery, the gestation in weeks, the length of labor in hours, birth weight, sex of newborn, the type of delivery, if it was vaginal or cesarean, type of anesthesia if they had any, and then any complications with mom or baby. And this should all be within their record. They typically do this on labor and delivery. They have all of this information that they have to go in and save. This history assists in identifying areas that may need to be investigated further or monitored during the prenatal period. Women with previous complications like premature labor, gestational diabetes, or postpartum hemorrhaging are at risk for having these problems again. The present pregnancy history establishes a baseline for the present health status of the prenatal patient. The patient is told about warning signs that can place her or the baby in jeopardy, like headaches, visual disturbances, abdominal pain, vaginal bleeding, and discharge. The patient is also asked if she's experienced any early signs of pregnancy, like nausea, vomiting, fatigue, spotting, swollen, or tender breasts. All prescribed or over-the-counter medications, including vitamins and herbal products, must be documented. Certain medications can cross the placental barrier and be harmful to the baby, and the patient should not be taking any meds unless the provider approves it first. The MA should document the first day of the patient's last menstrual period, which is used to calculate the due date / expected date of delivery. We do have these really cool things for the estimated date of delivery. Figure 8.11 shows a gestational calendar. So you'll line up the little lines. It'll say last menses began, and you'll line that up with when their first day of their last period was. And then it's going to show you the average, when they think that the conception was, and then it'll show the different weeks of when their estimated delivery date is, and then how many weeks they should be within, each day. Interval prenatal history. The purpose of this is to update the record. During every visit, information gets collected and documented, like weight, blood pressure, urine test results, bundle height measurement, and fetal heart rate. Also, fetal movement, Braxton Hicks contractions, how the patient's feeling, and any concerns or symptoms since the last visits are also written down. This assists in planning, implementing, and evaluating individual needs. And our main focus is on risk factors like hypertension, thrombophlebitis, and uterine bleeding. The initial prenatal exam, the purpose for this is the confirmation of pregnancy, so to ensure that yes, you are pregnant, and then it establishes a baseline state of health for the rest of the pregnancy. So preparation, we're going to get vitals, height, weight, tell the patient to disrobe, put on the gown. We're going to ask if their bladder needs to be emptied, get a urine specimen, assist them in getting on and off the table if needed, set up a tray with equipment if needed, and then position the patient as needed. For patient education, we're going to educate them about nutrition, what to eat, what to watch out for with weight gain, how much they're able to gain, and what that means. Rest, sleep, employment, exercise, travel, intercourse, dental care, smoking, alcohol, and drugs. The provider may also order lab tests to assess the patient's health and detect problems that could put the pregnancy at risk. So they might do a pap test, chlamydia, gonorrhea, some prenatal blood test. Group B strep and glucose challenge are scheduled later in the pregnancy. For urine tests, a complete urinalysis, including physical, chemical, and microscopic analyses of the urine, are performed. A clean catch midstream urine specimen is generally preferred for the test. If bacteria are found in the urine specimen, the provider usually requests a urine culture and sensitivity tests to determine the possible presence of a urinary tract infection. A pregnancy test also may be performed on the urine specimen if ordered by the provider. They can also do a pregnancy test and do the HCG test in the blood as well. For swab tests, we have the pap test, which we've talked about before. So I'm going to skip over that. And then we have the chlamydia and gonorrhea. If they do have this, they do need immediate treatment with an appropriate antibiotic to prevent any problems with her and the baby. If either one of these is present at the time of delivery, the bacteria causing these conditions could infect the infant's eyes during the passage through the birth canal. This can result in a type of conjunctivitis known as ophthalmia neonatorum, which, if not treated, could lead to blindness. This is one of the main reasons why you'll see babies get erythromycin ointment in their eyes, that little like greasy Neosporin-looking treatment that goes on their eyes to help protect them. For vaginal infections, if an excessively irritating vaginal discharge is present, the provider will get a specimen to rule out any bacterial infections, and then they're going to be treated properly. BV and trichomoniasis increase the risk of premature birth and low birth weight, so it's important to control it before delivery to prevent the development of thrush, which is a yeast-like infection of the infant's mucous membranes of the mouth or throat. Group B strep, we said this one is done a little bit later in pregnancy. It's usually done between 35 to 37 weeks of gestation. This is a common bacteria that's found in the vagina and rectum of healthy women. It's not harmful to a pregnant woman, but it can cause life-threatening infections in the newborn. While passing through the birth canal, a newborn can become infected with bacteria carried by the mother. When infected, the infant may develop an infection of the blood, septicemia, pneumonia, or meningitis. They're going to use 2 swabs for this and collect specimens from the vagina as well as the rectum. If it's found, they're going to get IV antibiotics while they're in the delivery process every 4 hours when they come into the hospital. In most cases, this antibiotic administration prevents the newborn from becoming infected. There are situations where they do become infected with it, so they get antibiotics immediately and they're closely monitored. We do have patients that come in every now and then that might not have been tested. Maybe they don't have any prenatal care, and typically they're giving these antibiotics anyway, just in case as precautionary measures. For blood tests, they might do a CBC, which is a complete blood count, and it's a basic screening test used to assist in assessing the patient's state of health. It includes hemoglobin, hematocrit, white blood cell count, red blood cell count, and a white blood cell differential. Platelet count, and also red blood cell indices, which if you were in my last class includes things like the MCH, MCHC, and RDW. For hemoglobin and hematocrit, they might do this separately. Low hemoglobin or hematocrit values are seen in cases of anemia. Prenatal patients have a tendency to develop anemia because there's an increased demand for and correlating increased production of red blood cells during pregnancy. If the value is low, further hematologic evaluation is usually required, and if necessary, therapy is instituted, which usually is in the form of a supplement and nutritional counseling. Hemoglobin and hematocrit values are checked again at approximately 32 weeks of gestation as a precaution against anemia before delivery. RH factor and ABO blood type. These tests are performed to anticipate ABO blood type and RH factor incompatibilities. If the patient is Rh negative, the possibility of an Rh incompatibility exists. This situation warrants the performance of an Rh antibody titer test and repeat antibody titers throughout the pregnancy to determine whether the mother's antibody level is increasing. An increased Rh antibody level could be dangerous to the developing fetus. It can result in severe anemia, jaundice, brain damage, heart failure, and sometimes death of the fetus. Next, we have glucose challenge test. This is performed between 24 and 28 weeks to look for gestational diabetes mellitus. This test works by assessing the body's response to a measured glucose solution. The patient does not need to fast for this test, and no preparation is required other than arriving at the lab at the scheduled time. To perform this, the patient is asked to drink 50 grams of a glucose solution, and her glucose level is measured 1 hour later. A woman with a glucose level of less than 140 does not have gestational diabetes mellitus, and there's no further testing required. If it's greater than 140, the test is abnormal, and they need to have further testing using the 3-hour glucose tolerance test. The syphilis test, it's the microorganism that causes syphilis is able to cross the placental barrier and infect the fetus, which can result in intrauterine death or could cause the fetus to be born with congenital syphilis. Infants with congenital syphilis are often born with deformities and may become blind, deaf, paralyzed, and develop intellectual disabilities. For the syphilis test, we're going to use the VDRL or the RPR test. The results are reported as non-reactive, weakly reactive, or reactive. Because these tests are screening tests, a weakly reactive test or reactive test result warrants more specific testing to arrive at a diagnosis. This is mandated by most states and is performed early in pregnancy, and treatment is required for a patient with syphilis. Next, we have the rubella antibody titer. Rubella, this is a titer that assesses the level of antibody against rubella, which is German measles, in the patient's blood and is used to determine whether the woman is immune to rubella. If the mom contracts this during pregnancy, serious congenital abnormalities can occur in the fetus. Patients who lack immunity should be immunized against rubella within 6 weeks of delivery. So after delivery. We talked about this just a little bit ago. Moms can't have this shot while they're still pregnant because it can harm the baby. Rh antibody titer or Rh negative blood specimens. An Rh antibody titer detects the quantity of circulating Rh antibodies against red blood cells. These can occur in a pregnant woman who is Rh negative and is carrying an Rh positive baby. The titer is performed on all Rh negative blood specimens. Repeat titer levels also are performed during the pregnancy to determine whether the woman's antibody level is increasing. As was previously indicated, an increased Rh antibody level could be dangerous to the developing baby. As a preventative measure, Rh negative women with the potential of having an Rh positive infant and who test negative for Rh antibodies are given 2 injections of Rh immune globulin, aka RhoGAM. This prevents the formation of Rh antibodies in the mother, which avoids Rh incompatibility complications during the next pregnancy. The first injection is given at 28 weeks of gestation, and the second is given after 72 hours of delivery, or within 72 hours of delivery. Hep B and HIV, the CDC recommends that pregnant women have the hepatitis B surface antigen test to screen for hepatitis B virus. Women who have a positive result have increased risk for spontaneous abortion or preterm labor. In addition, the mom may transmit Hep B to the infant, particularly during delivery or in the first few days of life. This risk can be greatly reduced by administering the hepatitis B immune globulin, HBIG, and the vaccine within 12 hours of birth to the newborns of women who have tested positive for Hep B. Infants born to women who are HIV positive are at risk for developing the disease. If antiretroviral drugs are taken during pregnancy and the infant is delivered by C-section, the chance of transmitting HIV to the infant is reduced significantly. Okay, next part that we have is return prenatal visits. These provide the opportunity for a continuous assessment of the health of the mom and the baby. During each visit, essential data is collected and documented in the prenatal record, resulting in an updated record at each visit. If signs or symptoms of a pathologic condition are present, the provider performs select aspects of the physical exam as necessary to diagnose and treat the condition. Between 0 to 28 weeks of gestation, every 4 weeks they're going to come in for a visit. Then from 29 to 35 weeks, they're going to come in every 2 weeks. And then 36 weeks until delivery, they're going to come in every week. The return prenatal visit also provides the opportunity for the provider and the MA to lend support to the mom to provide her with ongoing prenatal education to reduce apprehension and anxiety, and to ensure that the mother is well informed to prepare during her pregnancy, childbirth, and the postpartum period. The MA plays an essential role in prenatal education and should take the necessary time with each patient to provide appropriate information and allow the patient to ask questions. The patient is asked to provide a urine specimen during each return prenatal visit. The medical assistant is responsible for testing this for glucose and protein using a reagent strip and documenting the results in the record. A positive reaction to glucose can indicate the development of gestational diabetes or a pre-diabetic condition. And a positive reaction to protein may indicate a urinary tract infection or preeclampsia. Further testing usually is needed to arrive at a final diagnosis and to institute treatment. Hypertension is the most common medical disorder of pregnancy and occurs in 10 to 12% of all pregnancies. Because of this, the MA must make sure to obtain an accurate blood pressure measurement. During the return visit, the provider performs one or more of the following procedures depending on the stage of the pregnancy: palpation of the woman's abdomen to measure fundal height, measurement of the FHR, the fetal heart rate, and a vaginal examination. Something I'm going to say about the blood pressure measurement: we want to make sure that we're taking it the right way and the most accurate way. We want to give them a little bit of time to sit down and get kind of rested after, walking back to the room and everything, because that initial stress of getting to the appointment and then that walking down the hall, that can cause the blood pressure to increase. And I can't tell you how many times we would have people when I was working on labor and delivery that the patient would come in, they'd get sent down to labor and delivery because their blood pressure was high, and it turns out they were A, just anxious, or B, they had taken their blood pressure as soon as they had gotten back there. So we want to make sure that we get an accurate one by waiting for a little bit. The first fundal height measurement, which is usually performed during the first prenatal visit, is used as a guideline for all subsequent measurements. The provider measures the fundal height by placing one end of a flexible, non-stretchable centimeter tape measure on the superior aspect of the symphysis pubis and measures to the crest or top of the uterine fundus. By 20 weeks, the fundus reaches the lower border of the umbilicus, and between 36 to 37 weeks, it reaches to the tip of the sternum. During the first and second trimesters, measuring the fundal height provides a rough estimate of the duration of the pregnancy. In addition to assessing the duration, the fundal height measurements permit variations from normal to become apparent and are used to assess whether fetal growth is progressing normally. Growth that is too rapid or too slow must be evaluated further by the provider as a possible indication of high-risk conditions like multiple pregnancies, polyhydramnios, which is where they have a lot more amniotic fluid than normal, ovarian tumors, intrauterine growth retardation, which is where the baby is growing, not growing as much as they should, the baby's smaller, intrauterine death, or an error in estimating the fetal progress. Fetal heart tones refer to the heartbeat of the fetus as heard through the mother's abdominal wall, and the fetal heart rate is the number of times per minute the fetal heart beats. The normal fetal heart rate is between 120 to 160 beats per minute with a regular rhythm. A very slow or rapid FHR usually indicates fetal distress. These tones can be heard with a Doppler fetal pulse detector between 10 and 12 weeks of gestation. And this detector converts ultrasonic waves into audible sounds of the fetal pulse. After the procedure, the MA should remove any excess gel from the mom's abdomen with a paper towel, or give her the paper towel and let her clean it up herself if she's more comfortable. And then you'll clean off the probe head using a damp cloth or a paper towel. Because air is a poor conductor of sound, we have to have that gel spread on the mom's abdomen in the area to be examined. The gel is usually applied by the MA, and its purpose is to increase conductivity of the sound waves between the abdomen and the transducer. In the absence of vaginal bleeding, Vaginal examinations may be performed at any time during the pregnancy. However, in a normal pregnancy, there is usually no need to perform a vaginal examination until the patient nears term. The vaginal examination is usually begun approximately 2 to 3 weeks from the estimated due date and is performed to confirm the presenting part and determine the degree, if any, of cervical dilation, which is where the cervix gets bigger, and effacement. Effacement is when the cervix gets thin. The purpose of dilation and effacement is to permit the passage of the infant from the uterus into the birth canal. So special tests and procedures are next section here. The pregnancy can be evaluated with one or more of the following special tests and procedures: carrier screening, first trimester prenatal screening, non-invasive prenatal test, multiple marker test, obstetric ultrasound scan, amniocentesis, and fetal heart rate monitoring. These are not considered routine tests and procedures. However, they involve a slight risk or no risk at all to the mom or the baby. We're going to go through each one of these, and the first one is carrier screening. This can determine if a woman or a partner carries a gene for specific genetic disorders like cystic fibrosis and sickle cell disease. In many cases, both parents must carry the same gene to have a child affected with a genetic disorder. Carrier screening can be performed before or during the pregnancy. The test is performed using a blood specimen or tissue sample that is swabbed from the inside of the cheek. Next, we have first trimester prenatal screening test. This is known as an ultrascreen. It's a prenatal evaluation available to pregnant women between 11 and 14 weeks of gestation. The purpose of this is to assess the patient's risk of certain fetal genetic disorders, which include Down syndrome, trisomy 18, and other less common chromosomal abnormalities. The first trimester prenatal screening test cannot determine the risk of a neural tube defect like spina bifida. This does consist of a combination of the following two tests: a blood test to measure a protein and a hormone present in the blood of a pregnant woman, and an ultrasound to measure the fluid accumulation behind the neck of the fetus known as nuchal translucency. Next, we have a non-invasive prenatal test, an NIPT, which is also known as a cell-free DNA test. And it's a laboratory test used to assess whether a patient is at increased risk of having a fetus affected by certain genetic disorders. During pregnancy, some of the DNA from the baby crosses into the mother's bloodstream. This DNA carries the baby's genetic information. This fetal DNA is tested to check for certain genetic disorders that include Down syndrome, trisomy 13, 18, and problems with the number of sex chromosomes. This test can also determine the gender of the baby. This NIPT can be performed as early as 9 to 10 weeks of gestation and up until delivery. Next, we have multiple marker test. This is also called a quad screen, and it's a laboratory test available to pregnant women between 15 and 20 weeks of gestation. Its purpose is to screen for the presence of certain fetal abnormalities that include neural tube defects, Down syndrome, trisomy 18, and ventral wall defect. Because the multiple marker test has a high incidence of false positive test results, it's not a mandatory prenatal test. However, the AGOG believes that this test should be offered to all pregnant women regardless of maternal age. If you do have an abnormal test, it does require further testing through an amniocentesis. Next, we have an obstetric ultrasound scan. There are two different types of these scans as well, and we kind of go over them on this in the next slide. So an obstetric ultrasound scan is a diagnostic imaging technique similar to sonar used to view the fetus in utero. So used to view the baby in the uterus. It allows continuous viewing of the baby and shows baby movement. An ultrasound technologist usually performs this procedure, and then if there's anything that they see, they have to get the doctor, and the doctor is the one that can interpret some of those results. They can't usually give you any results. The primary purpose of an ultrasound scan is to evaluate the health of the fetus and to determine the gestational age. This is accomplished by viewing the image of the baby and by taking various measurements of the image, such as crown rump length, biparietal diameter, which is side-to-side measurement of the fetal head, femur length, and abdominal circumference. There are two methods, like I said earlier. We have transabdominal and we have endovaginal. So transabdominal is the scanning method performed most often. The patient must have a full bladder for this exam. It's accomplished by instructing the patient to consume 32 ounces of fluid about 1 hour before the procedure. A full bladder acts as an acoustic window through which the sound waves can travel to provide a clear visualization of the uterus. In addition, a full bladder holds the uterus stable and pushes away any bowel that might interfere with the image. The patient lies on an examining table in a supine position on their back, and they're draped with the abdomen exposed. A coupling agent in the form of a liquid gel is applied to the patient's abdomen to increase the transmission of the sound waves. An abdominal probe containing a transducer is placed into the gel, and the probe is moved slowly over the patient's abdomen. The image of the fetus is displayed on the screen of the monitor. Next one that we have, this one is the first one that they're going to have when they find out that they're pregnant, and the patient should be aware that they're going to have this type because it can make some people uncomfortable. In the early stages of pregnancy, up to 12 weeks, endovaginal scanning is preferred over transabdominal scanning. This is because when the baby is really, really small, your uterus is small, the baby is small, it's harder to see. You have more tissue to go through on the abdomen. So with the endovaginal, they can see things up a lot better. The patient is going to have an empty bladder for this scan. So the abdominal, they have to have a full. The vaginal, they have to have an empty bladder. This makes the examination more comfortable and allows them to see better. The patient is placed in the lithotomy position, and a vaginal probe is placed in the patient's vagina. The image of the embryo is displayed on the screen of the monitor. This scan provides a clear visualization of the uterus at the beginning of the pregnancy because the probe is situated in the vagina, which places it closer to the uterus. Next up, we talked a little bit about this a second ago. In amniocentesis, we mentioned that word, I guess. This is a diagnostic procedure that can be performed between 15 to 18 weeks of gestation. This is going to aid in the prenatal diagnosis of certain genetically transmitted errors of metabolism, congenital abnormalities, and chromosomal disorders like Down syndrome. It's also used to detect fetal jeopardy or distress, and later in pregnancy to assess fetal lung maturity. Amniocentesis also can determine whether the fetus is a boy or a girl. To perform the procedure, the provider inserts a long, thin needle through the mom's abdomen and into the amniotic sac surrounding the fetus. An obstetric ultrasound scan is always performed in conjunction so the provider can view the position of the fetus, placenta, and amniotic fluid. This allows the provider to know the exact place to insert the needle. The provider withdraws a sample about 1 tablespoon of fluid, which contains fetal cells. This is then sent to a lab for the study, and it usually takes 1 to 3 weeks to evaluate the amniotic fluid and report the results. This is only offered to women whose pregnancies are at risk for fetal abnormalities and includes women who are 35 years or older, women who have a child with a genetic or neural tube defect, women who have abnormal multiple marker test results, women who have or whose partner has a chromosomal abnormality, and women who are or whose partner is a carrier for a metabolic disease. Fetal heart rate monitoring is performed later in the pregnancy to obtain information on the physical condition of the baby. Specific conditions that may warrant this procedure are fetal growth that is not progressing well, decreased amniotic fluid, decreased fetal activity, elevation of the mother's blood pressure, gestational diabetes, and an overdue infant. There are 2 kinds of fetal heart rate monitoring, the non-stressed and the contraction stress test. The non-stress test monitors changes in the fetal heart rate in response to the baby's spontaneous movements. The mom is instructed to press a button when she feels the baby move. Nowadays, you can actually see this. They'll be hooked up to like a little contraction monitor and then a fetal heart rate monitor, and you can actually see this on the little screen that they have, so they don't always have to do this anymore with the button when the baby moves. In a normal test, the baby's heart rate increases when the baby moves. To prepare for the NST, the mother must be instructed to eat a light meal within 2 hours of the procedure to stimulate fetal movement. If the results of the NST are abnormal, a contraction stress test may be performed. This test is similar to the NST except that mild contractions of the uterus are stimulated for a short period of time. This is used to evaluate the response of the baby's heart rate to the contractions to determine whether the baby would be able to withstand the stress of repeated contractions during labor. If the results of the test are abnormal, further evaluation is required to evaluate the well-being of the baby and determine how and when delivery of the baby should be carried out. Next up, we have the 6-week postpartum visit. This is kind of where we're bringing this chapter to an end. So the puerperium includes the period of time in which the body systems are returning to their pre-pregnant or nearly pre-pregnant state, which usually takes about 4 to 6 weeks after delivery. During this time, numerous changes occur in the woman's body, so the uterus obviously has to get back to the size that it was. This also includes healing of any injuries sustained, so if there were any tears or if they had to do an episiotomy, or if there were any injuries to the birth canal inside. During the puerperium, the patient is going to experience vaginal discharge shed from the lining of the uterus. This is known as lochia. Lochia consists of blood, tissue, white blood cells, mucus, and some bacteria. The color is an indication of the progress of the healing of the uterus. So whenever you deliver a baby, they automatically start looking at the lochia and they start documenting it. For the first 3 days, the lochia consists almost entirely of blood, and because of its red color, it's called lochia rubra. By about 4 days postpartum, the amount of blood decreases, and the discharge becomes pink or brownish and is known as lochia serosa. By 10 days postpartum, the flow should decrease and the lochia should become yellowish-white, which is known as lochia alba. Lochia usually continues in consistently decreasing amounts from moderate to scant to occasional spotting and becomes paler in color until the 3rd week after delivery, when it usually disappears altogether. It would not be considered unusual for discharge to last the entire week, 6 weeks. However, everybody's different. Everybody's bodies are different. The patient should be instructed to contact the medical office under the following circumstances: if the amount increases rather than decreases, if the discharge is absent within the first 2 weeks after delivery, if it changes to red after having been yellowish white, which indicates bleeding, or if it takes on a foul odor, which indicates infection. Menstruation usually begins approximately 2 months after delivery in a non-nursing mother and about 3 to 6 months after delivery in a nursing mother, but this can be different for everybody as well. During the puerperium, the patient should be encouraged to avoid fatigue, to avoid lifting heavy objects, and to consume a nutritious, well-balanced diet that helps maintain health and promote healing. The physician will want to see the patient at the medical office at the end of the 6-week period. And the purpose of this is to evaluate the general mental as well as physical condition of the patient, to make sure that there's no residual problems from childbearing, and to provide the patient with education regarding postpartum depression and methods of contraception and infant care. During the postpartum examination, the physician evaluates the patient's general mental status and physical appearance, performs breast and pelvic examinations, and checks to determine whether the muscle tone has returned to the muscles of the abdominal wall. During the puerperium, atypical cells may be sloughed off into cervical and vaginal mucus as part of the normal healing process. Because of this, the Pap test is not included in the postpartum visit. If the patient has problems with hemorrhoids or varicosities, which is very common, the physician discusses any further treatment required. If the patient does not have antibody protection to rubella, as has been evidenced through the prenatal lab test, she receives a rubella immunization at this time if it was not administered already in the hospital. In addition, hemoglobin and hematocrit determinations usually are performed on the postpartum patient to screen for anemia caused by blood loss during delivery and the puerperium. Responsibilities of the MA during the postpartum visit include measuring and documenting the patient's vital signs and weight and preparing the patient for the examination. For this chapter, we do have some procedures. So we have a breast self-examination. We do have fake breasts that I'm going to leave for you all to do. So there's a video to watch about the skill. There's a procedure in the back of the chapter. So I want you to read through those, watch the video, and then practice this in class. And then there's also assisting with a gynecologic examination and assisting with a prenatal exam. There are no videos that go with these, so for your exam, I just want you to read through those procedures A lot of what's in these procedures are already reviewed inside of the actual chapter itself. So just make sure you're going back through these and your chapter. If you have any questions about this one, just feel free to reach out to me and I will get back with you as soon as I can.